Well, good morning. We're going to start promptly. This is an incredible turnout today. Thank you. It's a holiday. It's a nice cold day. I live in Houston, and it's the first day it was below 90 degrees at 2 in the afternoon, about 2 days ago. This is a very important workshop. The National Cancer Policy Board, about, I think it's 11 years ago, put out a report under Joe Simone, which I advise you to look at if you're curious, because there were 11 or 12 recommendations, and they seemed very aggressive at the time. And when I look at it again, they seem very obvious, and most of them are happening, although not at the pace we like. And the goal of this workshop is to join with 2 other workshops and collect data to help us make another report. Now it's called the National Cancer Policy Forum, which we hope will have the same impact of pulling together the issues that have to be addressed that we're all aware of that lead to the crisis we've reached in healthcare, which is finding out how to provide value with better outcomes and reduce costs, just to summarize it in a sentence. So today we have, and tomorrow we have very exciting panels, but I am very glad to be able to introduce our keynote speaker, Dr. Harvey Fineberg, who has been the president of the Institute of Medicine, and before that, as you know, the provost of Harvard University, and then a distinguished career before that at Harvard School of Public Health. And we're very glad. I'm not going to say more because I'm interested in hearing what Harvey's going to tell us, so I'm going to turn the podium over to him.
Good morning, everyone, and thank you so much, John. It's such a pleasure for me to have this opportunity to speak with all of you, and I know there are a number of people also listening in on the webcast this morning and throughout this conference. The topic is so timely, it's so important. The problem of cancer touches each and every one of us directly and indirectly. Ourselves, our family members, those of us that we have as clinicians that take care of patients, those of us who are supporters and helpers to those clinicians and to our family members and loved ones who are living with cancer. It's a problem that's ubiquitous in our society. It's a disease that for most people is a fearsome disease still, and a disease that creates more anxiety and also more dread than almost anything today as a major threat to health. And yet it's a problem that we know we are making progress in dealing with it. We know there is opportunity to do much more and opportunity to do what we do in a much more effective and efficient way. And that's really the purpose of this gathering, affordable cancer care. I want to just say a couple of background points, maybe elements of approach when I think about the challenge of affordability, because I think that it's very easy to get distracted with the concept of affordability in ways that take us down what I think of as either dead ends or very short streets leading nowhere. And I'll just say in a minute what I mean by that. But I want to make 3 foundational points about the concept of affordability, particularly as we think about it in connection with the needs of cancer patients and cancer care. The first critical point is that there's no way to talk about affordability without simultaneously having in mind the quality of care and the best of care. There's no point in thinking about lowering costs if you don't simultaneously have in mind that you're maintaining and improving the quality of care. If you think about it in healthcare, if your whole objective was to save money, the cheapest thing is to let people die where they fall. Don't do anything. That's very inexpensive. It's extremely affordable. It's totally the wrong thing. And so when we think about affordability, we have to have in our mind at the same time the issue of the quality of care that we are delivering in an affordable way. And so thinking about the improvements in care and results and the cost and the efficiency of delivery go hand in hand. Trying to do one without the other is like trying to clap using one hand. So we have to think about both. The second point that I would like to offer about the construct of affordability is there will be no escaping the question, affordable to whom? What do we really mean by affordability? I can tell you from my own experience around the time of the discussions and debates on the Affordable Care Act, participating in town hall meetings around the country, that in general, when most people were talking about the affordability of their health care, they meant what it cost them out of pocket to get the care that they need. When you turn to your health economist colleagues or to the policymakers in this town, the policymakers and the government officials are often concerned about the affordability to the public purse because the nation is running such a huge deficit that if we're concerned about the fiscal future of our country, which all of us have to be, and we look at the ways in which our country is spending money and where it is spending money in ways that don't seem to be retrievable, the so-called entitlement and other pre-commitment programs, there's no escaping that public expenditures for health is a large and driving part of that problem for the public purse. And there's no escaping that when you look at the cost drivers for health, that the expensive diseases automatically crop up and come into the sites. But the second construct of affordability, which is it affordable to the government? Can we have public programs that will support and sustain the needs of people who don't have otherwise access to care, is also an incomplete construct of affordability, no more complete than the construct to patients, and no more complete than the construct to employers or other payers, no more complete than thinking about where does the money actually come from, in which purse, and how does it move around in order to cover the total costs of care, directly and indirectly, who's contributing and who not. Because cost shifting is no longer a feasible solution to the affordability problem. We're not going to save individual costs over time by simply shifting to government. We're not going to save government by simply shifting it to insurers, which is really employers, which is really the public. We're not going to save the affordability by making it less affordable for individuals, since a major disease like cancer is still a principal source of bankruptcy, personal bankruptcy in the United States. The lesson of this is that when we think about affordability, we have to think about the total cost of care. It does not make sense to drive only toward making it affordable for the person, affordable for the government, affordable for the employer. Yes, we have to do all of those. That's a question of fairness and a question of justice and a question of policy trade-offs that are, in the end, going to be a public decision through our elected officials. But if we're going to succeed in reaching an affordable cancer care and indeed an affordable health care system, we have to focus on the total costs. So affordability has to be grounded in thinking about what is also best care and what is the total cost of care. So I have to think about those two foundational elements for affordability. And a third very important point to me on affordability is that if we're going to succeed in making care more affordable, we have to be willing to look simultaneously at many strategies that will reinforce one another and lead to a system that can produce more affordable care. It will not be enough just to say we'll make it more affordable by improving the technology over time to bring in less expensive technology. It won't be enough to say we're going to make it more affordable by shifting the tasks of our workforce so that we can get more done by people in a way that will make it more efficient because they cost less and can do more compared to others. It won't be enough just to think about the ways in which we'll focus on prevention, because preventive strategies, which by the way don't even enter the thinking of individuals about their personal care, because until you have cancer, you don't think you're spending money on cancer. But prevention as a social strategy is very important, but it's not going to be enough alone to solve this problem. Reorganizing in accountable care organizations and patient-centered homes, utilizing our existing outstanding cancer centers and creating networks that drive to every state and every community high-quality cancer care. It's another essential component. It's also not alone going to be enough to solve the problem. Looking at a more concerted effort to undertake the research that's necessary to compare what works and what doesn't work, that alone is not going to be enough. Developing more effective communication to patients and the public about what works and what does not work, that's not alone going to be enough. We're going to have to come to grips with the reality that if we're going to get our arms around the totality of the problem, we have to be prepared to use every tool in our toolbox. We have to be creative about inventing new tools. We have to be willing to experiment and pilot test. We have to be prepared to extend and implement what works and what saves money at the same time. We're going to have to worry about the payment system. The existing payment system in oncology is even more distorted than the usual fee-for-service system in most of medical care, because in so much of oncology today, so much of the resources that come into practices is also dependent on what exact treatments you undertake. What other specialty is that true for in the direct care of patients? It's a problem that we're going to have to face up to. And the task, I think, of this conference over the next day, today and tomorrow morning, is, I think, to come to grips with these realities, to come to grips with outstanding care at the same time we worry about costs, to come to grips with the fact that we have to look at the total cost, to come to grips with the creative application of new solutions and a willingness to look honestly at what's working and to figure out how do we get that done in more places, more quickly, so that we can achieve ultimately a health system that is not only outstanding, but also affordable for everyone. Affordable for patients, affordable for employers, affordable for the government, affordable for our country. It's a big task, and it's not an easy task. Everyone has a part in it. I think one of the most challenging ethical aspects of this concern is involving the patients in a constructive way. And I hope you'll be thinking also in the course of these days about what are the most successful ways of engaging patients, and also what are the boundaries of engaging patients. And if you take a concrete example, like the role of Avastin in breast cancer, or when should you have mammography, or you name it, for the many aspects of cancer diagnosis and treatment for which the evidence is lacking. You'll have to come to grips with what is the limit, if anything, to patient-centered care. Is it simply and only what the patient wants? And if it is what the patient wants, who then is responsible or should be responsible for paying? I have a rather peculiar philosophy about insurance. Most of us think that insurance for health care is what we are entitled to get and our insurer pays for it. I think insurance is a compact by which each insured person agrees to pay for what the others need. And if you think about your insurance as your commitment to pay for others, and conversely their commitment to pay for you, it puts a very different light on the questions of what insurance should cover. And you'll have to come to grips with these very challenging, ethical, technical, scientific, but also very human tasks. So affordability opens a wide array of critical challenges. But I would say this: if working together we can find a way to solve this problem for cancer care, then I think we have the keys to solve it for health care more broadly. And if you can make progress on this critical task in the next day, you will have made an enormously important contribution, not only to our nation, but to every patient today and who will need help because of cancer. Thank you all very much.